If you've ever felt the crushing weight of a migraine attack, you know that the word pain barely does it justice. In clinical studies and patient surveys, severe migraine attacks are frequently rated as more debilitating than kidney stones, fractures, or even childbirth. When you're in the middle of that storm, you'll do almost anything to make it stop. I know I used to. You reach for the box of triptans or the bottle of NSAIDs because you simply need to survive the day. But I want to ask you a very important, though perhaps frustrating question. Could the very thing you're relying on to manage this awful pain actually be worsening the severity of it for you? Yes, this is a very real possibility, and it affects far more people than most realize. It's called medication-overuse headache. And today, we're going to look at the science of why this happens, and more importantly, how we can break the cycle and start your renaissance. An important note before we dive in, I do not mean that medication doesn't have a valuable role to play here. In fact, preventative medication use can be critical for some people's recovery journey. So let's get into the hidden global burden. We used to think of medication overuse as a sort of side issue. We now know that it's a significant driver of disability worldwide. According to the Global Burden of Disease study in 2023, the numbers are staggering. In the general adult population, about 1 to 2% of people live with medication overuse headache. But a recent meta-analysis by Hussoy et al. Indicates that the global prevalence of medication overuse headache may be as high as 4.1% in adults aged 18 to 65. That is a major difference. This comes out to tens to hundreds of millions of people seriously suffering worldwide. Perhaps the most impactful finding from the 2023 Global Burden of Disease study is this. More than 20% of all health loss attributed to all headache types was actually due to medication overuse. Specifically, over 15% of health loss attributed to migraine and more than 50% for tension-type headache is driven by overconsumption of acute pain relief meds. In our migraine bucket framework, imagine your rescue meds are meant to bail water out of your bucket, or perhaps temporarily prevent some water from flowing in. But in medication overuse headache, the medication eventually starts acting like a leaky faucet that stays on 24/7. Your bucket never gets a chance to empty because the medicine itself is keeping the water level high and can even shrink your bucket over time, making your trigeminal system highly sensitized. So, are you in the overuse zone? How do doctors actually diagnose this? The International Classification of Headache Disorders sets pretty clear criteria for this. First, headaches occurring on 15 or more days per month in a patient with pre-existing headache disorders. Also, regular overuse for more than 3 months or so for one or more drugs that can be taken for acute or symptomatic treatment of headache. And it has to also not be better accounted for by other ICHD diagnoses. But overuse can look different depending on the drug. Not all medications are created equally here. According to the Department of Veteran Affairs and the EAN guidelines, triptans, ergotamines, and combination analgesics, like those containing caffeine, only take 10 days per month to trigger medication overuse headache. Simple analgesics like NSAIDs, that'd be like ibuprofen or naproxen, or acetaminophen in the non-NSAID category, are recognized to take about 15 days per month to trigger medication overuse headache. But the VA guidelines also highlight that opioids can induce medication overuse headache in as few as 8 days per month, and short-acting barbiturates like Fioricet can do it in just 5 days per month. That is a pretty serious elevated risk. It's important to also note that medication overuse doesn't affect everyone equally. It disproportionately affects females, with ratios estimating the range is about 2 to 1 or maybe even up to 3.6 to 1 female to male, and typically peaks during the busiest years of life, between 35 and 54. Also, individual variants can play a really important role in medication overuse headaches too. So, now we know that medication overuse is a serious issue, but how do we better understand the risk of this developing so we can get ahead of it? It's critical to proactively focus on early identification before episodic migraine turns into a chronic struggle. The Department of Veteran Affairs have noted that several associations significantly increase the odds of developing medication overuse headache. So high headache frequency, which is having 7 to 14 or more headache days, whether they're tension type, cervicogenic, migraine attacks, etc., per month, increases your risks of developing overuse headache by 19 times. That is a massive, massive risk. But also just having a history of migraine increases your risks by 8 times. Using other medications such as anxiety meds or pain-relieving meds for other conditions and sleep-inducing medications are all linked to elevated risks. As a general recommendation, the American Headache Society recommends that people should limit acute medication use to an average of 2 headache days per week. But as you can tell, this does not account for the much higher risk medications such as opioids or the short-acting barbiturate medications. As a general recommendation, the American Headache Society recommends that people should limit acute medication use to an average of 2 headache days per week. But as you can tell, this does not account for the much higher risk medications such as opioids or the short-acting barbiturate medications. If you find yourself exceeding this, it should be a prompt to consider more proactive preventive therapeutic approaches rather than just more rescue meds. Yes, this can include medications, but also the 7 pillars of migraine renaissance are critical here too. So now let's get a little bit more into the science of medication overuse, headache sensitization. So you might be wondering, why is a painkiller causing more pain? It comes down to how these drugs interact with your nervous system over time. While the mechanisms differ between drugs, the risky medications share a common destructive path. They promote sensitization of the trigeminal nerve and facilitate central sensitization, basically shrinking your migraine bucket. Essentially, your brain becomes extra effective at experiencing pain and becomes more effective at having headaches and migraine attacks. The threshold for what triggers an attack drops lower and lower. In Robin's case, which we'll look at in a moment, her brain was essentially learning to be in more pain because of a variety of interconnected factors. But also, the consistent presence of these drugs altered her brain's chemistry and pain processing pathways. To understand how this can progress, let's look at Robin, a composite case that mirrors so many people that I speak with. I was going to use a specific client story, but sometimes these cases are so specific that I had a hard time keeping it anonymous and protecting their privacy. Robin's headache story started when she was about 26 years old, after having her second son. She had experienced some random, infrequent headaches in the past, but it wasn't until this last pregnancy that she started having diagnosed migraine attacks. She started with about 2 migraines a month on average. They were painful, but manageable with a triptan. Let's say sumatriptan here. Then, life got stressful. Her new baby added a wonderful but challenging extra variable to life. Sleep quality, duration, and consistency dropped off as she was up throughout the night, helping calm her newborn. Her visits to the gym dropped, then stopped altogether. She felt like if she didn't have time for a full workout, there wasn't any point in going. Neck pain started creeping in, making it harder to find a comfortable nursing position, let alone workstation posture. Over the course of the next 6 months or so, she fought to return to working while navigating this major life change. Her migraine attack frequency increased to once a week. She started taking ibuprofen on the off days for what she thought were tension or stress headaches. She needed to power through the day, and this seemed like the logical way to do it at the time, because she didn't want to overuse her triptans. By the end of the year, Sarah was waking up with a dull, muddy headache almost every day. She assumed her migraine condition was just naturally progressing. She wasn't having much luck getting answers from her medical providers. She assumed her migraine condition was just naturally progressing, and she wasn't having much luck getting answers from her medical providers. Robin's MRI and CT scans were normal. She should be in perfect health according to those pictures, right? This pain hides behind the functional neurological changes that are invisible to most imaging types. To get through her morning work meetings, she took a triptan. By the afternoon, the rebound would hit, and she'd reach for the combination analgesic. Without realizing it, she was now taking acute meds 22 days a month. She knew that it wasn't the best to take the over-counter pain meds, but she thought that that was just for stomach ulcers or something like that, and her stomach felt fine, so she just pushed on. That muddy daily headache wasn't her original migraine. It was the withdrawal symptoms from yesterday's medicine. She found herself trapped in a loop where she was treating the side effects of her last dose with her next dose. Robin's migraine bucket was shrinking and perpetually overflowing. Her trigeminal-vascular system was now in a constant state of high alert. If Robin's story sounds familiar, please know that there are fairly clear evidence-backed paths out. The European Academy of Neurology and VA guidelines highlight a gold standard approach that integrates education, withdrawal, and prevention. The first step is not always necessarily a new pill. we need to find some clarity. It is critical to recognize the cyclical nature of medication overuse headaches. You need to know the rationale for withdrawal and expected timeline. As the EAN guidelines emphasize, education must precede any pharmacological interventions, so here we are. But you should also consult your trusted medical provider if you suspect this is something you're facing. Next, let's get into the withdrawal protocols and actually bridging therapy too. So for those overusing simple analgesics, such as ibuprofen or acetaminophen, or maybe triptans, which could be like Maxalt or Imitrex, or ergot derivatives such as Migranol or Cafragot, evidence supports that it's actually safe and effective to stop cold turkey in most outpatient cases. However, this might not be optimal for many people, and careful conversation with your provider is critical here. Tapering, bridging therapy, or preventative medication use at the same time might be better options. For tapering, especially for people taking opiates, barbiturates, or benzodiazepines, a gradual taper is advised to avoid complications like anxiety and sometimes very serious drug withdrawal symptoms and syndromes. And then bridging therapy. This is often used for reducing the symptoms, and bridging therapies are sometimes short courses of corticosteroids, such as prednisone or prednisolone, and antiemetics, which are drugs that help to prevent nausea and vomiting, can help manage the temporary spike in headache and other related symptoms during withdrawal. But we now really need to talk about the role of preventive medication therapy. A 2020 randomized controlled trial published in JAMA found that starting preventative medication is a cornerstone for reducing the burden of medication overuse headache management, aligning well with the growing body of literature on the subject. Their study showed that combined withdrawal plus preventative medication led to the fastest reduction in headache days and the highest rate of reversion to episodic headache, with about 74.2% at 6 months, compared with preventative medication alone, which was about 60%, or withdrawal alone, which is about 41.7%. Topiramate has pretty moderate evidence specifically for chronic migraine with medication overuse, though that can carry relatively high side effect burden such as cognitive impairment and other issues like that. Anti-CGRP monoclonal antibodies are one of the most significant advancements in recent years for chronic migraine and medication overuse headache. Temper et al. Found that ireminab, a CGRP monoclonal antibody, had significantly higher rates of absence from medication overuse headaches compared to placebo, and CGRP meds carry little to no risk of medication overuse headache, which is very important. These medications also generally offer a superior safety and tolerability profile compared to topiramate for migraine prevention, with significantly lower rates of stopping their use because of side effects, though the rates of improved headache days and migraine-related disability are pretty comparable. Botox is FDA approved and demonstrated to reduce headache days by approximately 8 days per month on average in medication overuse headache populations and those with chronic migraine. So this is a pretty significant tool for us to kind of rely on sometimes in these situations. And I've seen many people actually using this strategy, and it works quite well for many people. So let's talk about how the 7 pillars factor in here. While medications absolutely have their place in comprehensive migraine management, they are only a relatively small part of the story when we zoom out and consider people with migraines as more than just someone struggling with headaches. These medication strategies can help to manage symptoms, but they really miss the mark when it comes to an effective total health perspective and actually getting people back to doing what they love and supporting a long, healthy, and vibrant life. The 7 pillars of migraine renaissance are critical for managing migraine and medication overuse headache because they provide the infrastructure to support your nervous system through the withdrawal phase, but are also critical foundational pieces of rebuilding capacity and resilience. For example, Pillar 1, efficient, effective exercise, provides these tailored progressive movement strategies that help to build resilience. It provides a natural endorphin release that, when done correctly, doesn't trigger rebound. It provides a natural endorphin release, which, when done correctly, doesn't trigger a rebound and actually can improve your resilience. This has actually also been shown to reduce migraine attack frequency by up to 52% on average when done correctly. Pillar 2, sleep optimization, and Pillar 4, stress management and nervous system resilience. These are your natural anti-sensitization tools. When you withdraw from medication, your nervous system's hypersensitive state is very poorly regulated. Prioritizing effective support of your circadian rhythm and nervous system regulation, like effective stress management, breath work, heart rate variability tracking, biofeedback, etc. These rebuild your migraine bucket, setting the stage for the other pillars to do their work. And of course, we have to factor in pillar 7, which is sustainable behavior change and community. This is sort of the how to this whole process. Pulling from the frameworks like the trans-theoretical model of change, the COMB model, and making SMART goals, while having the support and structure to put it all together effectively into your life, help you have the highest odds of successfully making it through the withdrawal process, even when it inevitably gets challenging. Really, integrating all of the 7 pillars of migraine renaissance effectively creates a combined health and migraine management strategy that addresses you as a whole person, not just a headache with a body. So, what are your action items for this week? To move from thinking to doing, let's try doing these steps this week. Conduct a 30-day audit. Look at your calendar or your migraine tracking app. On exactly how many days did you take any acute medications, such as triptans, NSAIDs, acetaminophen, etc.? Identify any double dipping. Are you using multiple medications like an NSAID or a triptan to try to avoid crossing that overuse threshold? Remember, they all count towards the total days of medication use. Now, we also need to seek some clarity. If you find you're bordering on overuse, schedule a visit with a trusted medical provider to discuss a formal withdrawal and prevention plan. Managing this is complex and often best done with clinical support to make sure you're safe in this process. But of course, we cannot forget the community side of this. Breaking the medication overuse cycle can be one of the most challenging first steps a person with headaches can do. It requires the courage to stand at the foot of that often daunting recovery mountain and choose to take that first step. I'm currently building a dedicated community for those of you who are actively fighting back and searching for social support. I'm calling it the Migraine Renaissance Collective. It'll be a space for shared experience, community connection and support, and where we embody the frameworks needed to make these changes stick. I want to know though, what's the number one thing that stops you from reducing your rescue medication use? Is it the fear of pain, the demands of your job, simply not knowing what else to use, or something else entirely? Reply to this email or comment below. I really do read every single reply, and your feedback is shaping how I build this community and how I create these resources. So keep an eye out. I'll be unveiling the collective very soon. Until next time, I'm with you on your journey to recovery. My name is Dr. Dylan Wells, and I'll see you next week.